So I'm Camilla from Hamilton. I am a respiratory therapist, and funny enough, I actually worked here as a new grad RT about 8 years ago. And then I went over to Mercy Ballas, so I'm very familiar with the Mercy system, but now I work for Hamilton. So these are your guys' Hamilton C6 ventilators. You will see them in all ICUs now. The only time you're gonna see that AV event is if the patient is on Heliox. And I can guarantee you guys aren't moving Heliox patients, probably. No, we don't want that. Too many things. But the nice thing about the Hamilton C6 is, as you can tell, it is a transportable ventilator. That's why I can't turn it. But it is a transportable ventilator. It has a 3-hour battery life and it only needs oxygen. So the nice thing for you guys, if you have to walk, especially your trach patient, I don't think we're walking too many ET2 patients, but if you have to walk your patient on the ventilator, this is now very easy to push. If you trust your patient not to hit too many things, you can even have them hold on to this or have your partner, of course, walk with the ventilator as well. Please ask RT first that. I don't know what the protocol is going to be for walking ICU patients. I know hospitals are developing that, and that is awesome for our ICU patients, but whatever RT's protocol is, please ask. But looking at the ventilator, so all ventilator companies, we patent our modes, which is why our modes are always something slightly different. That's not ours. So all ventilator companies patent our modes, which means our modes are called something slightly different, even though they all do the same things. Typically, I do have a mode comparison card that will tell you what your ventilator mode was on your previous vent and what it's called on the Hamilton vent, but this has been my teaching one, so it's on all the ICU ones. So your vent in the room will have a mode comparison card, but the most common mode that we are using here right now is our SCMV mode, which is your traditional volume control mode. It's a mode most ICU patients go on for whenever they're first intubated. So that is where we're gonna have a set tidal volume and our set respiratory rate as well. All of the patient settings are always gonna be on the right-hand side of the screen. Everything the patient is doing is gonna be over on the left-hand side of the screen. What type of parameters are you guys looking at whenever you're doing therapy in the room?
We're looking at the peak, the pressure support.
Okay, so you're more, this is our control mode, and you're more so whenever we get to spontaneous.
Mm-hmm.
So spontaneous is going to be, obviously for our spontaneously breathing patients, you will see spont up in the corner, and as long as our patient is gonna spontaneously breathe, you will see these little pink triangles pop up as well. But then, yep, you can see our PEEP and FiO2 is gonna be down here for you. The nice thing is, typically, I have taught RT that whenever they have a patient that we are weaning to hopefully extubate, we'll have this, what we call vent status screen up. Now my vent status screen is looking at extubation criteria, and once the patient can get their parameters, so their oxygenation, CO2 elimination, and spontaneous activity, once that patient can get all of their parameters down into that white area, you're gonna see a giant green timer. Giant green timer means your patient's been ready for extubation based on X amount of time. So especially for our neuro patients don't have lung issues. They get to this point a lot faster than our respiratory patients. So a lot of your neuro patients that you guys might be doing therapy with might have a green timer that says even 12 hours, 18 hours or more. That's just telling you that that green timer is telling you that their lungs are healthy enough that they can come off the ventilator, but obviously they're still on a ventilator for another reason. So if you do see that giant green timer, that's just letting you know that this patient is getting closer to extubation. It's a good indication for you guys. If the green timer goes away, which right now I'm breathing too fast for my vent, but if it does go away, just that's letting you know, hey, the patient might be breathing too fast, breathing too shallow, or something changed where they might need a moment or two to recover. So the vent status screen is always something nice to have if, there's our green timer, if for whatever reason RT forgets to put it up, just touch a box, and again, it's called vent status, and then you can have that box up there for you as well. Now I'm gonna switch it over to probably is gonna be the number one unfamiliar mode for you guys, and that is gonna be something called ASV, or adaptive support ventilation. ASV is a Hamilton specific mode. You will not find this on another ventilator. What it is RT will set a minute ventilation. Minute ventilation is our respiratory rate and our tidal volume multiplied together to tell us how well our patient is working to breathe. So by setting a minute ventilation, that allows the ventilator then to choose the patient's respiratory rate, tidal volume, eye time, and pressure, and adjust all those settings in the background, keeping the patient comfortable. It also allows the patient to go from a control mode, where the ventilator is doing all the work of breathing for them, to eventually a spontaneous mode where the patient is doing all the breathing on themselves. So a lot of our doctors here are already big fans of ASV, which is awesome, but that means it's a new mode that RNs, RTs, and you guys have no idea what's going on with their patient, so I'm here to try to help you guys understand that. Again, vent status screen is gonna make sure, letting you know that we are ready to wean, but also we have our ASV graph here. We talked about pressure, and I love the fact that you guys pay attention to pressures on our ventilator, because we all know that want our pressures to be low, or at least below 10 when we're getting towards extubation. On this ASV graph right here, you can see this 19. That 19 is the pressure being given to the patient. So that's really, really high for our inspiratory patient, because my test lungs are always these ARDS type lungs. So right now this patient's requiring lots of pressure to be given. Looking down here, F controls mechanical rate, F spontaneous is our spontaneous respirations. Why do you guys care? Because if our patients are riding the ventilator, that means our patients are too sedated to follow along with your guys' therapy as well. So if you walk into the room ready to do therapy and your patient's on ASV and you see that they're not spontaneously breathing, you're welcome to wake them up however you normally wake up your patients, or that might be an indication for you to go find a nurse and ask them to lower the sedation, because ideally on ASV, we want to see our patients spontaneously breathe. The benefit of ASV is once our patient begins to spontaneously breathe, the ventilator is going to back off on that mechanical rate, and it's going to allow the patient to dictate their own ventilation. This allows us to get our patients off the ventilator very fast. And with you guys, I don't know if you guys do breathing exercises while you're doing therapies, but ASV will allow the patient to breathe in whatever pattern they see fit. So they get a little more control with this versus being in other modes where the ventilator is more demanding, telling them how to breathe, and it alarms a lot more. ASV, as you guys can see, hasn't alarmed yet on us. So now that we can see F control is 0, this just means the patient's doing all of their own spontaneously breathing on themselves. They are now in their own SVT. So this is just what ASV is able to do, is that patient can go back and forth from a control mode where the ventilator is supporting them completely to spontaneous mode where they are controlling the ventilator. So you guys might be seeing this a lot more in your guys' units. I just want you.
I was gonna say, why is there a set one if you can just do that then?
Why do we have other modes?
Yeah.
I love that
Probably
question.
a silly question, but
Not a silly
I'm trying
question.
to
So it's doctor driven, because doctors like to control our vent settings, and with ASV, we have an algorithm controlling our vent settings. So now a physician can't come in and say, I want this patient to have a tidal volume of 500 every single breath. Instead, ASV can give them a tidal volume of 170 or go up to 600 the next breath, all based on that patient demand. So physicians like to have control, and that's why a lot of them don't like ASV.
Okay.
The physicians here have been trained at other Hamilton facilities. They trust ASV because they know that that algorithm is best for the patient, and now they're getting less phone calls, less ABGs, happier patients.
Okay.
So it's a learning curve for a lot of physicians, just because if they haven't used the mode before, they have to trust
Sure.
the algorithm.
And that would be scary.
Exactly.
Yeah.
So you have Dr. Stoll, Dr. Ravel. They came from Mercy Vallis, where we've used ASV there. So you'll see them use it more here. Versus your doctors that have been only at Mercy South, they may not jump on it. Like Dr. Speck, I'm gonna pick on him because he's been here forever and a day. He's not gonna jump on ASV. So it's more doctor driven
Okay.
than anything. But yes, we're gonna say that ASV is an awesome mode and all patients should be on it, but that's the main reason.
So have the studies been done that ASV is more effective in weaning patients off the vent versus
Several.
the other?
Several. So we have hospitals throughout the country and throughout the world that have done studies. Most of the studies relate to our open heart patients, because those patients we want to extubate in less than 6 hours, and ASV can typically get those patients off within 2 to 4 hours, as opposed to respiratory and nursing takes about 6 hours to get those patients off. So, but yeah, there are several studies out there on ASV. Mayo Clinic does their own protocols for ASV as well. So it is definitely out there. But coming down to our buttons, so regardless of the mode that you're in, red silence button is telling you that your silence timer is activated. So our silence time is always going to be 2 minutes for our alarms. Just make sure that whenever you guys are getting ready to leave the room, you hit this button again, activating those alarms, so that as soon as you walk into the room, that patient doesn't pull that tube and self-extubate. Nobody knows that when that happens. Increase O2, if you're putting your patient through a workout, you can hit the increase O2 button. It's going to give you 100% for 2 minutes, turning our FiO2 green. If you don't want it to go for the whole 2 minutes, you can hit that button again, and it's gonna go back to previously set oxygen. Lung button is gonna be our manual breath button. If you have a patient that gets winded while they are doing steps or walking, or I don't know what you guys do in the rooms with your vented patients, but that lung breath is just giving them some positive pressure. So if they're having issues catching their breath, you can just touch that button and it's gonna deliver a positive pressure breath.
Could someone do harm by pressing it too much?
So it's not gonna let you overbag the patient,
Okay.
it's only gonna deliver the breaths when it can, when your
Okay.
patient can. If you hold the button, it can hold the patient's breath. This is something nurses do whenever they're pulling out a chest tube. It will hold the breath for how long your finger is down for, or 15 seconds, whichever comes first. Makes it uncomfortable if your patient is conscious and you're holding their breath for 15 seconds, they will probably fight you on that,
Yeah,
but
we would never.
the
admit
vent
to
will,
it.
yes.
Anyway.
Is that
We-
only
we
on
want
the
your
ASV
breathing.
mode, or
This
can
is
you
all
overdo
modes.
it on other
Yeah.
modes?
Yep, this is all modes. All these buttons are gonna work the same regardless of the mode that you're on. This is just a save key. RT might have a flash drive into the side port behind the screen, and anytime they hit that, it's just taking a screenshot of the ventilator. Screen lock button. If there is a untrustworthy family member in the room, RT, RN might have this screen lock button on that prevents people from touching the screen
Oh my
or turning off the machine.
I didn't think that they would.
We had one yesterday.
Really?
Yeah.
It
We had
happens. We've had
Twice on the
ICUs that
time.
let children in, and they have to use
Oh.
screen locks to stop kids from hitting things we don't
Ours
know
was
about.
an urgent care nurse family member.
Oh,
She wanted to,
even better.
yeah,
Yeah.
so the nurse had a lot.
So the nice thing is, if RT, RN, or whoever has the screen lock button on and we don't want to clue in the family member how to turn it off, our silence, increase O2, and our bagging button all still work even with that screen lock button turned on. So we can still save our patients without cluing the family member in. If we hit the screen button, we can go back to touching the screen. So it's fairly easy to unlock the screen, but yes, that is, I like to call it my helpful family member button. We don't like those helpful family members. If RT, yes. If RT is giving a nebulizer, you're gonna see my spray can bottle is gonna be green the entire time they are giving a nebulizer. It will automatically shut itself off. Don't think you guys are doing therapy on continuous neb patients, so if it is a patient that's on Velitree, you'll see that light green the entire time that they're on that neb. And then of course, this is going to be our power button, standby button. Don't think you guys will be the ones putting it in standby, but just in case something happens, there's our standby button right there as well. Couple things with the actual circuit. So this week, the reason why I came back is because we went live with our humidifiers. So we don't have a temp probe line that you guys are used to seeing on your others. We still have our flow sensor line, but this circle up here is where our thermometer is sitting for our circuit. So ideally, whenever you guys are leaving the room, our flow sensor tubing and this temp probe need to be facing up. And ideally, we're gonna have that circuit at a 45-degree angle to help with that prevention. So if you guys could help us with that circuit, we greatly appreciate it. That little temp probe that sits in there just hangs down. So that way, if we ever have that circle facing down, then all of that water and condensation is sitting on that temp probe, and then we can't effectively humidify the air for them. So that's why we want that circle to be facing up, so we don't cause any condensation or any troubles to our heaters. One of the things that I forgot to mention in the beginning, along with our modes, so our modes are called something slightly different, and alarms, I'm sure you guys are unfamiliar with a lot of the alarms as well. If you guys are ever in a room and you don't know where RT, RN is, and there's an alarm going off, you can touch it as it's alarming, or hit this red eye, touch the alarm again. It's gonna give you a definition of that alarm and troubleshooting advice as well. This way you can determine if the vent is suffering a malfunction. It will tell you to take your patient off and to begin bagging your patient. Or if it's just a routine alarm, like it could be saying the humidifier water is low and RT or RN just needs to spike another water bag, or you guys can't.
So I was working with a patient yesterday, the alarm actually, it said what it was on there, it displayed it.
Yes,
It said circuit disconnect patient side.
yes. So
So it kind of
circuit
freaked me out because it went off twice and there was no disconnect, but, so I ran out of the room and.
was that in 21, 24?
No, it was on 3.
It was on 3, okay.
Yeah,
So
so it kind of scared me because I'm like, why?
I feel
So-
like during therapy that happens.
Yeah.
Oh, no,
I-
it was range of
I feel
motion,
like
it was,
we're
it
all
was,
like, oh, we've had that, but what does
Yeah.
that exactly
No.
mean?
yeah, no, the patient wasn't being moved, it was just,
Yeah. So a couple things could happen. A, Obviously, trace all your lines back, make sure everything is connected, blue, white, our flow sensor probes. But what can happen if you were getting that patient to swallow, or if they were coughing too fast, breathing too fast, they can actually,
It said patient side,
with the way that they're breathing, because we have a flow sensor at the end, it's doing all the measurements here. So if that patient is coughing and breathing too fast, it can trick the flow sensor into thinking they have a disconnect from the patient right here, when in reality the patient is coughing and inhaling at the same time, and the flow sensor can't predict that. And so that's why that alarm went up, cleared itself, went up again, then cleared itself. Because as soon as that
That's
patient
making
returned to a
sense.
normal respiratory rate,
I see it all the time,
That
I'm like,
happens a lot.
yes. And that's because
it's going back also.
this flow sensor is giving more accurate data than your guys' V events used to give, but because the flow sensor is nearest our patient, all of our information we're getting at that exact second. So the ventilator is just giving you that brief alarm letting you know something funky happened, but as long as that alarm doesn't stay consistent, then it already fixed itself. But yeah, flow sensor is gonna be more sensitive, which is a good thing because it can clue us into things that patients are doing. But yeah, you guys might.
There's also one that goes off, which alarm is it when there's too much condensation towards the trach site, or the
Check flow sensor tubing.
same thing?
Yeah. So, and that will
Sometimes I've seen
happen.
water just hanging out
Yes.
in there.
Yeah. And you guys can, and that's the important thing with the 45-degree angle, and either using the suction catheter to get that water out, or draining it back into the circuit so that it doesn't go down into the
So
patient's
maybe just try to
trachea.
lift it up to drain it out
Yeah.
and see if it comes out.
Because the inside of these, they might look corrugated, but the inside is smooth. So all you have to do is hold it up to gravity, and it's gonna go back. If it's in the blue limb, it's gonna go back into our chamber. If it's in the white limb, then it's gonna eventually make its way out the ventilator.
It's
as
like
well.
they're positioned a lot where the tube is like up against the person's chest, like the blue and white tube is on their chest, sitting in a curve, and there's just a pool of water in there.
Mm-hmm.
That is something we are working on trying to get RN, RT, because we don't know who's doing it, of course, because turn team is a factor as well. The corrugated tubing that is hooked up to your suction catheter, that clear tubing, it's not heated, which means as soon as we have our humidified air that leaves our heated wire, it's gonna pool in our non-heated zone. The non-heated zone is that corrugated tubing, and so that is just something that I'm training RT this week to be, okay, you have water gathered there, we can adjust our humidifier settings, help the rain out so that it's not as much, but RT would either suction that out or dump it out one way or the other. But because that corrugated tubing is unheated, that's why you guys see those condensation gathering there, just because these two circuits are heated, our suction catheters are not. Make sense? Yeah. But no, this week has been lots of talks about circuit placement and how to make sure that A, our patients aren't drowning ourselves, and our flow sensor isn't getting drowned at the same time as well. So great questions.
So really, like, how therapy can help with, so if we have them on the edge of the bed,
Mhm.
sometimes we like more slack, so sometimes we'll either have it hanging or we'll have it hooked on there.
Around
Is it preferable, like, to have it hooked on there at a nice angle, so we don't mess with anything?
Depending on what you're doing and depending on that patient's comfort, a lot of trach patients are constantly afraid that the weight of the circuit is too much for them and it's gonna
Mhm.
pull their trach out.
Okay.
So I've had it before where I have secured it to the patient's shoulder
Okay.
and, you know, with either a wrap or a piece of tape to their patient gown. That way they feel the weight on their shoulder and not the weight at their trach site.
Oh, good tip.
Yeah.
We never know what we can, like, I never wanna like cross any boundaries, but like, I also wanna make sure.
It's a new
So,
world.
yeah.
No, absolutely.
So it's nice to have little therapy
Yeah.
tips, especially with movement,
Yeah.
that we know we can help the patient and be safe.
And you guys have the vent circuit arm too that you can use and manipulate, but I know you're gonna get that patient to move, so it's a lot easier if you
There's
can
not a lot
find-
of slack when you're using the arm.
Exactly. The
with
nice
movement.
thing is, whether you guys can see it or not, this circuit is 6 inches longer than the Fisher-Paykel circuit.
Ah.
So it is a little bit longer than what you guys are used to dealing with. But my recommendation is just secure it to the patient. A lot of times I came from a NICU, so we would always use hemostats and clip it onto the baby's clothes that they were wearing that day. or
That's good to
whatever they
know, I
had
think
on.
that'll make some people a
Yeah.
lot more comfortable.
Exactly, because as you guys can imagine, even our high flow cannula patients, anything that has weight pulling down on your face and you're already working to breathe, we don't want that. So anything you can do to take that weight off of the patient will definitely help, and shoulders work.
And then one more thing, I heard, and I guess now looking, we used to have the adhesive tape for the ETT patients, and it's a big topic, but then they weren't working well, so
They got recalled.
recalled.
Your Hollisters got
Sticking
recalled.
or
They've got recalled.
Yeah.
So now nurses are saying they're experiencing more of an issue of the ET tubes.
Slipping because
Slipping.
tape, yeah. Because anytime you're taping a patient, you need to be replacing that tape within 24 hours, because as we know, our face has oils, our breath is humid, sticky residues just don't handle well. But unfortunately enough, whenever you're replacing tape every 24 hours, you're ripping the skin. So I know RT is dealing with a lot of skin issues and skin breakdown, and do we tape, do we not tape? Grandma's cheeks are unfortunately enough getting ripped. Luckily enough, Hollister has started producing their new ET tube holders again, but they're being produced in another country. So we will see how long it takes for those Hollisters to get here, but that is a national-wide
Any
thing.
tip for therapy wanting to get somebody up with the ET tube that does not want that to slip out?
So if that suction catheter, and I wish I had one,
Or taping it to the shoulder again?
taping it to the shoulder, but also these tubings, even though we can manipulate it and swivel it a little bit, if you twist it, you can get it to change the angle as well. So
Okay.
those suction catheters, not the corrugated part, but the clear part,
Uh-huh.
if you can twist it, you can actually get that ET tube to stick straight out of that patient's mouth
Okay.
and just leave the circuit like that. So practice with your next or if you have a suction catheter up here, just twist it a little bit and see how it manipulates the ET tube. It's a trick a lot of us RTs are constantly being OCD with, that if you twist it a certain way, you'll get your ET tube to stick straight out instead of doing the fish hook. Because nobody likes the fish hook either. Fish hooks are gonna self-extubate. Yeah.
An intensivist was joking and saying, since we probably aren't gonna have OSHA anymore, we could just bring the old ones back. I thought that was pretty funny.
I can only imagine. Did you have a question?
Actually, my question was about the tape.
Oh, perfect, perfect.
I have a couple questions. So on the old vents, we used to get a lot of the alarms of like a low volume or high volumes. So with the setting that you're talking about, we really shouldn't hear that alarm anymore, right? Because it kind of automatically corrects if they're high or low?
As long as RT has their alarm set appropriately, yes.
Okay.
And you guys can see these smaller numbers off to the side of my parameters. Those are my alarm windows. So right now, my low tidal volume alarm is set at 190, which my patient's breathing 308 right now. If that patient were to take a smaller breath that was less than 190, depending on that rate, ASV might be okay with a smaller tidal volume. But if RT has those alarms too narrowed, you'll still get that alarm. So RTs are getting comfortable managing alarms as well, but if you do notice that if an RT, like if I increase this alarm and say I had it set at 300 because it's a 6'2" male and they shouldn't be having a smaller tidal volume than that, then right at 300, this might become a nuisance alarm. So sometimes RTs can have their alarms a little too narrow and it tends to be a nuisance to other departments like you guys are nursing. So if that's the case, just send RT a secure chat and they can adjust those alarm limits and you can hit silence knowing that it's just a low tidal volume alarm that's a little too narrow. Absolutely.
And my other question was more, from a therapist perspective, I always find that the arm on the vent side is always super tight, super stiff, super weak. Since that one is such more mobile, is there any kind of policy for switching sides of the bed every certain amount of time or anything like that?
No, that would be an RT driven protocol. You can switch the vent arm to one side or the other. You can take it off. The nice thing about this vent arm, so it's different as in this knob loosens all of our joints and where's my long wheel? This acts as an elbow. So you see my elbow joint here, I can rotate that where I want it and bend and manipulate my circuit arm wherever I want to go. So if your patient's not moving off the bed and you don't want to secure it to their shoulder because they could have a dislocated shoulder as well, you can use this vent arm 360 and get it to go whatever angle. Once you decide where or how you want it to be, tighten the knob back up. and then it's going to stay at whatever funky angle we have it on. It takes a whole lot more pulling for it to get it to come off. So these arms are really nice. Just, it's one knob to loosen all the joints, and then you can manipulate it and move it at any point. But I don't think RT is gonna have any issue with you guys moving the circuit arm. As far as moving the ventilator on the other side, I would just ask RT and RN. I don't think most of them are sticklers for that rule. That rule was a thing whenever I was here 8 years ago, and I didn't follow it, so they may not follow it either.
So how long is the tubing?
So the tubing is almost 6 feet in length.
So we always, when we get patients up, we go towards the vent most of the time.
Which your IV pulls on the other side. And
Yeah, so this looked like when you were holding it, looked like it could reach across the
It
bed
should-
comfortably.
Yeah, it should be able to. I mean, I can toss this over to you, and we can fit over across the bed if you guys needed to.
That was like really the kind of driven to where the vent was. And
Yeah, yeah, absolutely. That, and RT's never like having to get in the nurse's way. You know, they need access to their IV pumps. I need access to my ventilator. There's our low tidal volume alarm that we know is a nuisance. Last thing I have to say, because even though it was right in front of me, I forgot to mention it. So the last thing that we added this week is IntelliCuff. This is going to be our cuff monitoring system where it's monitoring and maintaining our cuff pressure to our ET tubes or trachs. It only works on air cuffs, so if you have a Bavona trach patient that's a water cuff, you will not see this. But any air cuff, you're gonna see this. Again, this is monitoring and maintaining our cuff pressure, which you can see reflected here. A normal cuff pressure for a patient is 25 to 30, unless they have some sort of swollen airway or might be a burn patient. But the nice thing is, if you are having them swallow, or if they're doing something weird and their airway starts to get swollen, the cuff pressure is gonna pick up on that our cuff pressure is going up, and it is automatically going to be evacuating the air out of our cuff. What's important for you guys is this is an additional line that is attached to the ventilator. So I am trying to get RTs to be in practice of keeping this in line with our circuit so that it's all gonna stay. But as you can see, it can be very far away from our circuit as well. This connection right here turns into a Chinese finger trap. The more we pull, the less likely it's going to break at the connection. Instead, it's gonna break at the weaker point, and our weaker point is our pilot balloon. So if this gets stuck behind a shoulder blade or in the bed rail and we pull on it, it's gonna end up pulling our pilot balloon off of our ET tube, and now we have to replace our ET tube. Nobody wants to do that because we all hate calling the physician when that happens. So if you guys notice that this is tangled, or if you don't want to deal with it while you're getting your patient out of bed, just like a Chinese finger trap, you're gonna push it in and twist for it to come off just like this. Gives you about 20 seconds before it's going to alarm cuff leak, so you can untangle it and then just simply reconnect, and it's going to apply the same cuff pressure. So when you disconnect it, it took me a little too long, it'll clear itself. So when you disconnect it, it is not changing the cuff pressure at all. It's not gonna take a little bit of air out, it's not gonna put air in. You guys can disconnect and reconnect, just if you're moving things around, absolutely. I just want everyone to be aware of this because nobody wants to pull out the pilot balloon. Questions?
How do you get, so I like having the little like pictogram of the lungs. And that's been on most of them, but there was one that it wasn't on, I was like, oh, I wish I could see that.
Yeah.
So how do you get that pulled up?
So just like that vent status that I told you about, touch one of the squares and it's called dynamic lung. Or if you wanna mess with your RT and have a lot of fun, you can come down here to graphics, hit layout 4.
Yeah, real big.
RTs hate this because we can't see our waveforms and we're nothing without our waveforms, but if you guys wanna have some fun, absolutely. And if RT or physicians, if they clutter the screen and they take away those dynamic lungs and you don't remember what I said to get them back, come down here to this home key, hit that home key, it's gonna take you back to our default screen and pull the dynamic lungs up for you. So you can hit that home button anytime and it's gonna pull up this exact screen for you.
Can I just practice that Chinese strap thing? I'm not actually gonna want to do it, I'm gonna tell the nurse to do it,
No,
but
I want
if
everyone
they
to
can't figure it
practice
out, I wanna be able to be like, this is how you.
Do we think doing this, I don't know how much we talked to RT yet about what our new policies will be with the new.
So our policy is if someone has an endotracheal tube and we are so much as sitting them up at the side of the bed, getting out of bed or walking, we have an RT RN with
I
us.
see Jana.
But we usually
It's a lot
do
easier
disconnect
than
the
I thought.
suction.
Yeah.
And this is another thing, we can disconnect while we're moving, and then reconnect within that 20 seconds.
Yeah, and if it
Because
alarms,
I do
it's
think
fine.
when we're turning, because we do turn a lot of patients. I mean, to me, that is a very likely point of getting caught that we really have to watch out for, because we don't want anybody having to get an ET tube replaced because of us.
Do you have any like handouts or pictures of like the screen and the buttons and what things do?
I sent one over to nursing. I'll send it to you guys as well, because yeah, it tells you, you know, your silence button, increase O2 button, and basically the things that.
I mean, I've been in the ICU again for a few months, and I'm like, I'm not gonna remember all this stuff.
No.
It's a lot. And
We're
it's
glad
new.
you're here.
Yes, absolutely. And I'm here all next week too.
Question,
Yeah.
the cuff
Try it.
sensor,
Mhm.
is that, you can tell me this is way off, but is that how RTs and speech therapists are doing more accurate inline speaking valves?
So
Or like, are they
the IntelliCuff is just maintaining
just
that,
maintaining? Okay.
but if they want to do an inline speak valve, then we just deflate the cuff.
You do?
Yep.
Okay.
Yep, which even as you guys are practicing, I can show you, if I come up here and hit deflate, it's gonna say, do you really wanna deflate the cuff? And I'm gonna say yes, and in just half a second, my cuff is gonna be deflated.
Oh, yeah.
Closer your fingers are together,
Look at
it
the
will
cuff,
pull it apart.
Anna.
Huh?
Look at the balloon. Deflated.
And then now,
She just
if
from
I
a
hit
button.
manual,
Oh.
now it's gonna inflate it
Oh,
for
it can
you.
reinflate.
Mhm.
See, I just wonder if our speech therapists might feel like they have an extra tool now.
So if you.
So, I
Part,
know
it's gonna get
at
tougher and tougher.
Mercy
So if
St.
you get
Louis,
real
right before I
close
left
to it-
there, we were training speech on how to suction and disconnect to put in the speak valve.
Okay.
Are you guys doing that here?
No, but
Okay.
I really feel like
Because
we could push ourselves, don't you?
Because at Mercy St. Louis, that's how we got our patients to talk faster.
This is
we
intubated,
got
so it is
speech.
becoming more of a thing as part of the ABCDF bundle, that speech is no longer canceling due to patient being intubated.
Yeah, from the last time I talked to them, I think they weren't doing a whole lot of that
No.
because it's so acute, and usually by the time they, like 3 or 4 days they're extubated, then it's kind of like.
They're
But I think
not.
I think that's what I
Because if
kind of
Mercy
heard.
St. Louis is doing it, and our acuities are the same.
Yeah.
They're doing it more so to get speak valve in line for those patients that have been on, you know, like your patients on neuro and sixth floor that have been on the vent for
I
a
think
month.
that's
We
why
do
they
have
don't do a
those.
lot, and I think
You
that's
don't
why they
think
don't
we
do
get
a lot of it.
I do think we get them.
Yeah.
Yeah,
Rarely.
I think previously though, we hadn't really.
Yes, so that's
But
why it was
now
never
we do.
used. And
And
I'm
if you
saying,
guys
like, this new technology might leak, I'm glad that this is all being.
If you have a contact at Mercy St. Louis, a speech therapist, reach out to the speech therapist at
Okay.
Mercy St. Louis, because they were the ones that approached us and asked us to train them, because it was the same situation here. We were short-staffed and too busy to be putting inline speak valves in patients, and speech wanted to give our patients voices. So they reached out to us. So I would reach out to the speech in St. Louis, figure out how
You have to
they
get
did
really
it.
close.
We all
together.
know all the Mercies want to mirror each other
It's
and
not
do
the
the
blue part,
same.
it's the white part.
So this would be a very easy policy for you guys to start, especially since you guys are all learning the vent together right now.
I mean, we could
That'd be
put it out
fantastic.
there.
Not related to that, can you like, now that you're like much closer to us with the vent, can you just go over the screens really quickly and just like what is and the things like that are more pertinent to what we need to know?
Yeah, so again, all of your settings are gonna be on this side of the screen. Your PEEP and your FiO2 are always gonna be the last two settings that you
And this
can
is your
see.
standard, this is kind of
Yep, this is your default
display,
screen, yep.
okay.
So the sides of the screen are never going to change. The center of the screen is what anyone can change. But all of these numbers are always gonna be in this order. Your controls are always gonna be on this side. So our peak, mean is just gonna be an average pressure. F total is gonna be the total respiratory rate. VTE is our expiratory tidal volume, and expiratory minute ventilation is our minute ventilation here. Otherwise, what other types of settings are you guys looking at?
Well, just like all the different screens that you can open as well, I know there's like a lot, the graphics and tools and
So
all that.
all the graphics is doing is just changing the layout of the screen, whether you guys just wanna see waveforms. This is gonna be our default of 2 waveforms, 2 boxes, and then these are just all boxes so that we can fully customize it and switch it to whatever we want to see on the screen. And then of course, that last graphic is gonna be our giant dynamic lung to show off. But it's fully customizable, just kind of based on what you guys are wanting to see information-wise as well.
And is there home screen, like some, just on the bottom left?
So yep, your home button's here. Let me just switch it to a different screen. So your home button's right here. If you hit that, it's gonna take you back to this default screen. So RT has already gotten used to, and some respiratory therapists have found their favorite screen. So if that's the case, you can still come down here, hit that home key. It's not gonna ruin their favorite screen, because as soon as they get back, all they'll do is go back to graphics, probably hit layout 3, and still be able to see the information that they want. So just use that home button to get you guys back to the default, what you guys are used to seeing.
Can you explain the percentage? I was sitting in on your in-service with the nursing staff yesterday.
The ASV, yeah.
Yes.
So our ASV, and trying not to make things too complicated, that percent min volume, simply put, RT is putting in our gender and height of our patients into the ventilator. So the ventilator knows what our patient's ideal body weight is gonna be. That percent min volume at 100%, we're simply telling the ventilator we want that patient to get their normal baseline minute ventilation as if they weren't on the ventilator. So right now I have a 5'9" male dialed in. He has a 71 ideal body weight, which means his normal minute ventilation is 7.1. So ASV will do whatever it can to maintain that 7.1 minute ventilation. So 100% is just baseline breathing for this patient. Anything above 100%, we're supporting them more, help eliminate that CO2. Anything less than 100%, we're challenging that patient to do the work of breathing on their own. So a lot of times you'll see us go less than 100% if we're waking up a patient from surgery, and they might be taking a little too long to wake up from anesthesia, whether they're a COPD or a ginger, because I'm married to a ginger, so I get to pick on him. And he's horrible about waking up from anesthesia. So they can use ASV, turn down that percentage, and that percentage is going to then say, hey, we're not breathing at our baseline settings. Their brain's gonna wake up, and their brain's gonna say, I need to wake up and I need to ventilate. So you will see RT and physicians turn that percentage down less than 100% until that patient begins to wake up and spontaneously breathe. Then we'll go back to their baseline. But 100% is our baseline for you guys, not extubating, because unless you want to pull the tube, but I don't think you guys want to pull the tube. For you guys working with your patients that are getting close to that extubation range, if my percent min volume is between 100 and 120%, that is extubation range. So that patient hopefully will get close to extubation. And again, that vent status screen that we talked about in the beginning, right here, is also going to be letting you know how close we're getting to extubation. Mm-hmm.
Speaking of extubation being on this spontaneous trial, so it measures how long, or times how long the patient's breathing on their own.
Mm-hmm.
Could you talk a little bit about that, the measurement of time, when it interrupts, resetting, because we do try to see patients when they're being trialed. So kind of what we need to be aware of.
So as far as if you see my green timer up on the vent status screen,
Mm-hmm.
so
And then kind of telling the doctor when the patient's ready for extubation, like how many minutes or hours they need to be breathing on their own and all those things.
So most of the time, that SBT, on average, we want the screen timer to be 30 minutes. Just AARC guidelines say that if our patient is doing an SBT, a spontaneously breathing trial, and they are hitting their oxygenation is less than 40% and less than a PEEP of 8, their CO2 has to be within an acceptable range, and something called RSBI, which is how fast they're breathing and how well they're breathing. As long as all those parameters are met for 30 minutes, we can talk to the physician about pulling the tube. Now, the thing that vent status screen or that extubation criteria can't figure out is my patient neurologically appropriate? Can they pull their head off of the bed? Can they cough and clear their airway? So that time helps us justify that we are ready to extubate, but that is not our end all be all. RT is still gonna be looking at our heart rate, our SATs, and everything else to make sure that it's still safe. But on average, most patients will wean for about 30 minutes. But if you do have a patient that has failed multiple extubations, a lot of times those physicians like to see that patient be on their trial for about 2 hours before we go to extubate.
What if we're moving someone who's on spontaneous, they sit up and things don't go well?
So the nice thing is, I don't think the physicians are gonna live and breathe by that green timer, so if you guys do something and that green timer disappears, or if we have to hit that increase O2 button. The nice thing is, if the patient can get themselves back into these parameters within 2 minutes, they get to keep that green time.
That would be a good way to see how well they're tolerating.
Well, that's,
moving
yeah,
and
I remember you
breathing
talking
on.
about that
Exactly.
last.
Exactly, so if you get them up and they start huffing and puffing as you just move them, as long as they can calm themselves back down within 2 minutes, they get to keep their time.
We found this in somebody's bed earlier, where does it go?
That's the cap to keep the circuit closed, it's trash.
Oh, so if I see it in somebody's bed, I can throw it away.
Okay.
Okay.
Archie
Ronnie
Archie probably pulled it off and
just
just forgot to throw it away, or they aimed it at the trash can and it was a bad shot, so yes. The red cap, it keeps our circuit clean.
We were trying to figure out where, we're
I
like,
know.
this is just in this guy's bed.
Yep.
Like, it
We don't
almost
know
looked
where it
like,
goes.
Like the suction canister, and I was like, I don't know.
Yep. But yeah, so that green timer, doctors aren't gonna live or die by that green timer. I've had plenty of physicians extubate without that green timer ever popping up. But if you guys are doing something, you're not gonna ruin the patient's green timer either. More
Sometimes we get a
likely-
little bit pushback when they're trialing to work with the patient.
Or it's a good thing because we're gonna know if they'll tolerate it. If
Yeah.
they get
I know, like,
extubated
why
and then they
are
try to
you
do
telling
therapy the next day and they
Kind of,
can't.
yeah, I mean.
That's my thing.
For real, no, RTs do like that, they're like,
Yeah.
well, some.
Yeah.
Some are like,
Yeah.
don't mess up this.
I mean, don't make
beautiful
them do
thing that's
jumping
going
jacks, but you
on."
know.
We're helping you save time by figuring out. I
Because,
think.
yeah, I mean, if you have to re-intubate them the next day because they can't tolerate movement, then there
Right.
wasn't
Yeah.
really a,
Exactly.
why do we extubate, you know?
Yeah. But no.
We
for-
just a stress test.
Yeah, a form of a stress
different,
test.
yes.
Are there any tubes and lines that could be on accident easily disconnected?
Not easily. You
Because
guys,
the other one, there was a cord
Oh my
underneath.
gosh, that was,
That
you
could-
guys even saw with me
that was the most
when I
terrifying
pulled that one off.
experience.
This gets real stuck on here as well. Like I pulled it off once and now I'm trying to pull it off again. So our circuits stay.
That I'm
on.
not worried about, but like
I'm
anything
used to those parts,
here-
like closer to the patient, but the stuff like on the
if we're
actual
moving
leg-
and it
Yeah.
got caught on something.
These aren't gonna come off your
Okay.
flow sensor tubing. I've ran over flow sensor tubing with the wheels before and it's not gonna disrupt
Okay.
anything.
Oh.
The nice thing is, say you were moving a patient and you didn't notice that there was tons of water in here and then you flooded our flow sensor and you can see water go into our flow sensor tubing. Yes, the ventilator is alarm and it's gonna tell you check flow sensor and it's gonna give you a whole bunch of alarms. But if something ever happens to our flow sensor, like we drown it, we break it, we crack it, something happens, the ventilator will go into emergency backup settings. Those emergency backup settings are 15 centimeters of water pressure and it's just gonna keep the patient ventilating until we can figure out the problem or get a new flow sensor. So if you drown the circuit and my ventilator gets angry, your patient's still okay. All you have to do, again, put the flow sensor up at that 45-degree angle. There is always 2 cc's of flow going through this tubing, so it will flush that water or condensation back out. Just might take a minute or so depending on how drowned the
Okay.
circuit got. But no, let it do its thing. If RT is in the room or if you guys feel like doing this, it's my trick that I always use. You can disconnect the flow sensor tubing, hold it up to your flow meter, and the flow meter will flush out your flow sensor a lot faster as well. It's a hack that a lot of respiratory therapists will use whenever that end tidal ultimately gets drowned because the end tidals are always gonna be drowned, so we use it so that we don't have to replace those devices.
Because the Apra events had a cord on the bottom, and
It was
if
like
you
some of the
moved it,
tubing.
it could just like come
Oh, that's
disconnected.
fine.
So this looks way better.
Yes, yeah, and even trying to get my chamber off, it's very hard to get even, this part. Everything is very tight, very secured, minus these, the filters. I mean, if you hit check it, you can probably get a filter to fall off, but you'd have to really be trying.
But that, it would still ventilate the patient.
If we are walking with a patient, how much time do we have with the oxygen tanks at a significant amount of ventilation?
So, it just kind of depends on your settings, how fast the patient is breathing. On average, I would say if you have a full oxygen tank and you're weaning patients anyway, so they should be around 30% and ideally not breathing like a choo-choo train. that tank should have any issues lasting 2 hours.
Oh, wow.
So, if you have a patient that is on 100% PIPA 15, breathing 30 times a minute, that tank's gonna last you 15 minutes.
Yeah, we're gonna be walking this.
So, please don't walk those patients. But, as you guys can see, if you walk into your room and your patient's 30%, satting 100%, try them on room air, because as you see with my ventilator here, I am not attached to oxygen right now. I am not attached to the tanks at all. The end of my oxygen hose is right here. On room air, my ventilator will power itself without being plugged into a gas source.
Oh, really?
So does that
So you're
just,
not-
that
it's
just
like
provides
plug-
like
you don't have to
21%
plug that in.
FiO2 air, it's
That's
just giving the
it?
pressure?
So you can try it
Okay.
before
It's
you
just,
take them.
so the patient's already getting air?
What, oops, sorry.
F
I know I was gonna forget that.
21% is room air.
So in the back here is our air entrainment center. The ventilator is pulling in room air from the back. There's a HEPA filter back here. This is how it's delivering room air to our patient, and this is how we get by without having that air hose. So if you can get your patients on room air, you can absolutely walk your, I would still have a tank there just in case they desat, but you can absolutely walk your patient without being connected to oxygen.
But when you say room air, we mean the 21%.
Yes.
Right, okay.
Yes.
Just not connected to a tank, but
Yeah.
still.
But
Not
still, if
additional.
you hit the oxygen button,
You would have to be
it'll be
connected to
switched.
oxygen.
Okay,
Yeah.
will it automatically switch to that?
If you're connected to oxygen, yes.
It will.
Yeah. And you can be connected to oxygen, and as long as you have 21%, it's not gonna be pulling from that tank. So you can conserve
okay.
your tanks, be connected, just so on the off chance if your patient does desat and you have to hit that 100% button, your oxygen tank's already hooked up and ready to go. So if you can get your patient down to 21%, you're not gonna be pulling from your tank. You're just gonna be pulling from the back of the ventilator. And then you don't have to worry about your tank drying. Yeah.
So as smart as these ventilators are now, because they feel very smart, how long before they're telling the patients to slow down their breathing or take a bigger breath?
We are not in AI territory yet.
But it feels like we're not far out.
It is a common joke in the ventilator world right now on which company is going to toy around with AI first. Our algorithm for ASV is very, very close to AI, but it is not AI. It is still an algorithm. You can look up the formula.
That's
I
gonna be
will not
cool.
memorize it.
Mm-hmm.
But it's
My brother was
fascinating,
learning
it is
something.
awesome, but it's also something that your guys' IT team has thoroughly interviewed us and interviewed the ventilator, making sure that our ventilators are not hackable. Because unfortunately enough, the closer we get to AI territory, the closer we get to people hacking our hospital
And that would
equipment.
be absolutely terrifying.
Yes, Grey's Anatomy all over again, yay! So yes, that is very much an IT concern. IT has made sure that this ventilator has deemed safe, but AI is a real thing. It is a real thing, and it could be coming, but not as of this moment.
A question about the trach tubing instead of this. It's a real issue. We set patients up on the side of the bed and the tubing just will not stay connected to their trach. It just constantly comes off. It's like nothing
Is it the
holds
suction
it
tubing?
into place.
So like the whole connection.
It's the whole thing.
The connection
it
just
just
on the
pops
side
off
of
the
the
tray.
to the tray, like that little
Yeah,
piece
that little
pops
piece.
off. Yeah.
My recommendation is grab another one, because those are supposed to be replaced every 7 days.
Oh.
I don't
Well,
know
that's
about
not
you,
happening.
but I can't look at that piece of plastic and tell you how long it's been on a patient, and RT can't tell you that, so if those suction catheters get that much humidity to them, they're gonna lose that ability, that
And
hard
they'll just
plastic,
continue to
and they're
pop
gonna
off.
continue to pop off. So
They
if
just
you're
need to
having that
replace
pop
it.
off, and more than likely that patient has had that suction catheters since they got their trach,
For sure.
grab another one. RT probably has one hanging on the ventilator, or I know they're in the supply closets as well. You
Mind
don't have
blown.
to replace that 6-inch tubing. If you don't wanna replace everything, just replace your connector.
We need your number and for FaceTime. Hey.
Absolutely. Absolutely. I only look up.
and you're like, just hold this here and I'll hold you up and this is all we're gonna do.
Yeah, but no, just swap it out. That's
And
telling
there's
you that
nothing
that's
worse
too
than
old.
like somebody that's sore already and you're like,
Yes, you're constantly pushing it back onto
it's
their
not my
throat.
favorite thing to do.
No, yeah. So I would recommend just grab a new one. And like I said, you don't have to replace the entire thing if you just wanna replace that connector, but yeah, those connectors are only deemed, good for 7
Never
days.
knew.